Marvin Goldfried is a distinguished professor of psychology at Stony Brook University, where he helped to develop the graduate program in clinical psychology. He's the co-founder of the Society for the Exploration of Psychotherapy Integration. Alan Francis is a professor of psychiatry and chair emeritus at Duke, and was chair of the DSM-IV task force. Marvin describes the evolution of his psychotherapy orientation as psychodynamic, behavioral, CBT, and eventually integrative. He practices, teaches, and supervises what works clinically using direct and indirect evidence base. Alan describes his approach to psychotherapy as whatever works, or no one size fits all. He was trained and taught at the Columbia University Psychoanalytic Center, but remains equally interested in brief, supportive, cognitive, behavioral, interpersonal, and family therapies. Please enjoy this week's episode.
Good morning and welcome to Talking Therapy. I am Marvin Goldfried, and my long-term friend, I didn't say old friend, my long-term friend.
You're right on both counts.
Alan Francis is here. And what we're going to talk about today is the question people have raised in various places, Twitter and otherwise, even before Twitter: should the therapist give advice? And we see lots of things where online where therapists say, I don't give advice. Advice is not therapy. And we have a lot to say about that. And Alan has sent an email just the other day, this lengthy single-space email with his thoughts. And I'm going to welcome you to unpack those thoughts.
Okay. First of all, I think most therapists have been trained not to give advice, like it's a terribly impure, unprofessional thing ever to give advice. And I think that's completely terrible advice to therapists. I think that some patients desperately need advice. Some therapists have wonderful advice to give. I think good and timely advice for certain people is life-changing, and that advice has always been part of human relationships. And to think that therapy is the one important human relationship where advice makes no sense at all is to misunderstand the nature of therapy.
Then why are some people so adamant and saying, no, this is not therapy?
Well, I think that advice can be a bad idea. So if advice is more geared to the therapist's narcissism or protectiveness of the patient, then maybe it's more for the therapist than for the patient. And sometimes it smothers patients. They would figure out what to do on their own way. Why should they be listening to advice from a therapist when they can do it themselves? Maybe much better for them, and the very act of figuring things out is important. And advice can be overdone. Advice, I think, should be given when clearly necessary, but only when clearly necessary. Otherwise, it loses its impact. And also, therapists can give lousy advice. So that it's not as if advice giving is all good or all bad. Like most things, it depends on when it's done, who's doing it, how it's done, and for what purpose.
Well, some therapists also do lousy therapy. So it's not the advice or the therapy, it's more the therapist. And
I think that what part of the problem is, and I think part of why this dogma pervades the field, incorrectly pervades the field, is that the therapist who you least want giving advice is the trainee. The trainee has little experience with life, little experience with therapy. The advice they give is less apt to be useful for the patient. So training programs tend to discourage advice, but then people who've gone through those training programs tend to think that that's the way it should be for their whole careers. And so I think what may make sense for someone who's inexperienced doesn't necessarily make sense for people who are experienced, but the training lingers on sometimes for a career.
Well, the interesting thing too, and this applies to not only beginning therapists, but more experienced ones, is sometimes advice comes in disguise. You can give advice. Let me give you some advice, or listen to me. That's obvious in the form of it. But what about a self-disclosure, which we spoke about in a previous podcast, where the therapist talks about her or his experiences with something, the function of which is to give information to the patients that maybe they should do the same thing. Is that advice or is that not advice?
I think most advice shouldn't look like advice. So the classic thing in cognitive therapy is to give advice in a Socratic fashion that doesn't necessarily look like advice, but really is. Like typical statement might be, "Have you thought of?" Or,
Have you thought?
"Happen if?" Or "How would you feel if?" Or "What are your options?" All of these are ways of conveying in a disguised form advice. And I think if therapists were more honest with themselves, they'd realize that many of the techniques that they think are pure and have nothing to do with advice really are an indirect way of conveying opinions.
It is an interesting distinction that's often made, at least within behavioral circles, not just behavior therapy, but behaviorism. And that is the topography, what something looks like, and the function, what it serves to do. So the topography is a question. So listen, have you ever thought of moving out of your parents' house? The topography of that is a question, but the function of that is to, what do they call it? Plant a seed so that something would grow. So it's silly to say we never give advice.
Yeah, and I think that there are many different types of advice. So we're using the term advice very broadly to cover all sorts of different informational and suggestive kinds of approaches. I think informational advice. So patients come in with psychiatric disorders. One of the things everyone should do is teach them about the disorder, teach them about the management. If the diagnosis is bipolar disorder, the person should know it's not a great idea to do shift work, to be changing time zones very frequently, to be using stimulant drugs. That's part of the education of the patient. I think it's a way of advising them about how to deal with their illness. I think sleep hygiene. Many patients present with sleep problems.
Right.
Are you not going to teach them about sleep hygiene and the various ways not using sleeping pills to deal with sleep problems? I think many psychiatric conditions are helped by exercise. Are we not going to tell people to exercise is a good thing for physical health and mental health? So I think a lot of things that are part of just general good standard therapist practice could be construed as directly or indirectly giving advice. It's a good idea to exercise. It's a good idea not to be using stimulants if you have bipolar disorder.
Right.
This is advice, whether we call it advice or not.
Right. In a decision as to whether to prescribe antidepressant meds for somebody who is mildly depressed, saying, well, exercise is probably a good idea because it's been found, this is giving information, but the function is giving advice.
Yeah, and a lot of the patients that I speak to, I tend to, especially at this point in my life and career, I tend to see people or speak to people who failed at every treatment. They didn't fail the treatments failed them.
Yes.
Nothing's worked.
Exactly.
They've been on every medication, they've been to 5 therapies, nothing's worked. So a lot of the work with the people I see these days or speak to these days has to do with demoralization and discouragement. They're giving up. And I think at this point, are you going to sit back and say, what do you think about that? You have to do something to help remoralize them.
Do you think some of this has to do with the therapist's notion as to what therapy is?
What do you mean?
Therapy is helping the patient to find their way.
Right.
They need to do it on their own.
Exactly right. And that works for certain patients who are very, very healthy and dealing with fairly stable life situations. It's a great model for the healthiest patients in the best life situations. It's a terrible model for people who have really severe psychiatric disorders, for people who have really terrible life situations and are in crisis, for people who have medical illnesses. for people who are facing a decision where the rest of their life will be determined on whether they make the right decision, that there are many situations where therapy is much more supportive than helping the people change their personalities.
Right.
I think the advice that you have to let the patient do it on their own is wonderful advice for those patients who can do it on their own. Absolutely dreadful advice for people who need supportive therapy, which will include much more advice and help in making decisions.
Right. And, there was a recent review, several reviews actually, by a colleague of mine, Clara Hill, at Maryland, and her colleagues. And they reviewed the literature on giving advice and suggestions. And they say, a lot of people say you should never do it. Other people say, of course you do it. And their conclusion is basically what you're saying. It depends. It depends on the individual. It depends on the problem. So one of the things they point out, for example, is people who feel they need to be in control, they need to do it their way, like Frank Sinatra. I did it my way. You don't give advice to these people. You package the suggestion in a way, in a question. Well, do you think it might make any sense for you to, let's say, move out of your parents' house?
I've been very interested in the topic of how to deal with perfectionists.
Yeah.
People always have to be in control, always have to do everything right, usually come to get therapy when something has gone wrong in their life and they feel they've made a colossal error, or they're paralyzed with indecision about what to do next. And here, I think one way of packaging advice, the questions are a great way of doing it. Another way is to use metaphors and proverbs and common wisdom. Like one thing actually that I learned from Judy Beck, this statement: being a perfectionist and having a happy life are incompatible goals.
Mm-hmm.
10 words, 12 words, powerful statement. And the therapy can change. It's not always the patient figuring out that being a perfectionist and having a happy life are incompatible goals. Sometimes saying it can make a huge difference. Saying something like, we learn from our mistakes, not from our successes. For someone who's always pushing to control everything, let the game come to you. When something doesn't work out right, next play. Little statements like that carry kind of a emotional valence beyond the little statement, I think are sometimes very useful. And I include that with advice. I think advice is to me a very broad term. Well,
because you don't do pure therapy. People who, and I'm not quite sure what pure therapy is, because Freud didn't do pure therapy. He said that you sometimes need to alloy the pure gold of psychoanalysis with the copper of suggestion. But there are some people who prefer to think of therapy as pure gold. And I once did something online with Twitter, and it was interesting. Some people would acknowledge that a therapist saying something could be therapeutic, but it's not therapy. So what that tells me is they have a notion of therapy. They have a prototype of therapy, and unless it fits that notion, it's not called therapy. It's my model or the highway, my way or the highway.
Yeah, I think the purists have done a great deal of damage to therapy in general, especially the trainees. I've had the experience with dozens and dozens of therapists who, beginning in their first year of residency, were brilliant therapists. They just had natural gifts. They were just good at it. And then I would like them a lot. When they left the program, I would refer patients to them, and I'd get complaints. I need another therapist. It didn't work with it. And I'd be surprised because I knew this was a great therapist. What's the problem? Therapist never talks to me. There's a word that because the training program is so geared to being pure, it prevents the therapist from ever learning, the training therapist ever learning to be comfortable with themselves, comfortable with the situation, to be able to say things that will be meaningful to the patient, because they're always risking making a mistake because they've been taught by purists. And I think that to the degree that training programs are pure, they're teaching a model that's a terrible handicap to a therapist becoming as good as they can be.
Yeah. In a previous podcast that I spoke about the very early days of behavior therapy, where we were being accused of manipulating patients by being directive. And the model that I have kept in mind, excuse me, is that yes, I can be very directive in teaching a child how to ride a bicycle. I can give tips, I can run alongside, I can do everything and do this, do that, do that. But the eventual goal is for them to have their freedom. And, this goes back to Skinner versus Rogers, when they had a debate. They had a couple of debates actually in the 50s. And Rogers said there's a natural growth process. Don't push the river, it flows by itself. Beautiful aphorism. And Skinner said, no, people learn. And I think the history of that, or the legacy of that split, still exists. And there are people who say it's all in the relationship. And the patient has to do all the work. You're not supposed to direct them. They have to learn how to grow on their own.
I think, as usual with most dichotomies, both sides are right and both sides are wrong. That it's like child rearing, that you don't want to be a helicopter parent and never let your child stumble or have to find their own way. On the other hand, you don't want to let your kid run in the fire because he hasn't been informed that maybe fire can be dangerous. So you have to find a balance. And I would be against anyone who's a purist and says, oh, I never give advice. I think that's just silly. On the other hand, I would be against those therapists who are directing their patients' lives in a kind of microscopic way and feeling that it's their responsibility to make sure that the patient never figures out what to do on their own. And I think that the balance here so far in the world, at least as I see it, has been too much in the direction of this purism that advice is always bad, that the patient will always find their own way and needs always to find their own way. And I think the people who espouse this have never worked with patients who have more severe psychiatric problems, who have more severe life problems. It's easy to stand back when people don't have terrible, immediate psychiatric, medical, or real life problems. It's more important to step in and help with different ways of looking at things, different suggestions and advice in situations where the situation is much more fraught.
There are therapists who would totally agree with you, who don't give advice and say that's not therapy.
What would they call it?
Advice. It could be therapeutic.
If it's not therapy.
I think this may be the crux of the issue. It just occurred to me. Tell me what you think. There's an implicit belief on the part of therapists about how people change, what the change process is. Sometimes it's explicit, but sometimes it's implicit, and that's ever present. So if their belief is that the process of change is self-discovery on the part of the patient, then advice is no good. Okay, so the question is, the dilemma may be, unless we can agree on what the process of change is, we may have these debates going on and on.
Yeah, that's a great comment, Marvin. Basically, it's how you define therapy and how do you define the process of change. And I think, to me, therapy has a very broad definition that the term makes sense whether you're doing psychoanalysis or working with someone who has chronic bipolar disorder or schizophrenia, and where self-discovery is a very small part of the treatment. To me, therapy is any kind of helping relationship where you're using your skill and knowledge about life and about people and about relationships to help the person. And if you have a very broad definition of what therapy is, then your application to any given situation will depend on what's the patient like. What were their problems like? What are their external resources like? What's my role like? And do I know something that will help them? If I don't have good advice to give, I'm going to keep my mouth shut. But is there something that really would help them at this moment make a decision that will change their lives in a useful way? And I can contribute to that with any wisdom I've accumulated through life and through the work I've done with other patients. To me, the idea, I'm going to stay pure and let this person decide for themselves makes absolutely no sense, especially if they can't decide for themselves.
Yes.
Very often people who have severe bipolar disorder, severe schizophrenia, severe OCD, severe depression, they're not in a position to do that process of self-discovery.
Right. So your notion is, and you this is a theme that you've brought up in several of our podcasts, saying, well, in my experience, I've worked with severely disturbed people, and the rules that you follow with other people don't always work.
Yeah.
And implicit in what you're saying is that the process of change for severely disturbed people may be different from the process of change for somebody who has a panic disorder. Certainly the process of change is different. Somebody who's depressed, somebody who has interpersonal problems. One size doesn't fit all disorders.
And often enough, the goal isn't change. The goal is just stability.
Yeah. No, I want to stick. Let's stick with process, because you have disagreed with me on Twitter with process. You're saying process research is crap. The only thing that awareness does is make pure ignorance, nothing else. And you were the big advocate of outcome research, not process research. So now, are you?
You think you caught me?
Have I twisted your mind or arm?
Caught me?
What?
You think you've caught me?
I don't know. Did I catch
Maybe
you?
you have. I'll have to think about that. It's an interesting point. I think that one of the ways of looking at this is that the psychotherapy research has tended to pick very homogeneous groups of patients.
I agree.
And so the findings can only be interpretable for people who have the very meet the narrow inclusion and exclusion criteria.
Yes.
And obviously, if we did research to show that psychoanalytic techniques didn't work very well with schizophrenia, we might demonstrate that that was true in the research format. But I guess most people assume that you don't have to do research on that that's a kind of no shit Sherlock.
Yeah. Okay. Well, we'll come back to this notion as to whether or not you think process research is. A lot of the process research.
I'm sure you'll never let me forget it.
I won't let you forget it. No. But I acknowledge that a lot of the research meets the needs of the funding agent more than the needs of the therapist.
Yeah. And I guess, however we understand this, I think we would completely agree that different patients require different things at different times, and that a therapist who's purely following a model will often have a tin ear to what the patient really needs at that moment.
I like that. Boy. Should write that out somehow. But that's very, very nicely put. It depends. It's like
let me give you an example of advice that stuck with me.
Yeah.
I have a friend who's 90 years old. He's maybe one of the best therapists I've ever known. He came from another country when he was 30 years old, and he was struggling to make the decision whether to come to America or stay in his native country. He was struggling with it, very ambivalent about it, tortured by the decision. And his therapist said to him at one point, just do it. And that solved for him the ambivalence. He came to America and had a wonderful life. What this captures for me is that the therapist wasn't controlling the patient's life. My friend was not a suggestible person who was going to just do anything anyone told him to do. But he needed permission at that moment to do what he wanted to do.
Mm-hmm.
And if you were pure, you would never say, just do it. You might struggle and let the patient struggle for years and never make a decision. That every once in a while, it makes sense to not be pure, to take the chance and to do what feels right in the room. However, saying that, I'm also aware of the fact that if you have an inexperienced therapist or a dumb therapist or a therapist who's, really sort of pressing forward his own agenda, the advice giving can be very detrimental to the person.
Right.
In the ideal situation, it's wonderful, but like most things, things aren't always ideal. And I like people who are cautious about advice. I don't like the idea of saying it's never useful.
Well, you said something, and this may be a good point to end on, which to me created a light bulb in my head.
Wow.
Yeah, a magic moment in
Magic.
podcast. Yeah, and you don't even know you did it. So I'm going to tell you.
That's the best part about magic moments.
Yeah. So okay, so here it is. Okay, you ready?
Yeah. Eager.
Okay. One of the processes of change, and there are many, is giving the patient permission to do something they may not have wanted to do or may have been fearful of doing.
Yeah.
Permission is the process. How that is translated into technique, it could be a homework assignment, it could be a suggestion, it could be a self-disclosure, it could be leading the person. The form that it takes will depend on the nature of the patient, how severely disturbed they are, whether they want direct suggestions or advice. But the process is permission.
You just gave me a magic moment.
Yes, what was that?
Now, I like the way that you're able to take the generalities that I make,
Yeah,
much more specific about them.
yeah.
How it goes from my general statement to permission can be conveyed to people in so many different ways.
When I was a graduate student, we learned a lot about Skinner. And I was never very enamored of him. I just didn't like that. But a few things that he said have stuck with me. And one of the things is the function, as we were talking about before. The function of something is to give the patient permission. It's okay to do it. And the technique can vary widely, but it can have the same function.
And permission is not something that a patient can come to just on their own, usually.
Yes. Well, sometimes they can.
Especially ambivalent patients.
Yeah, sometimes they can. There are different people. It depends on the person, depends on the disorder, and lots of different things.
But when you're talking about really ambivalent people, and many of our patients are ambivalent, the problem is they can't get to permission, and they may need a little push.
I think this may be a good place to stop for now.
This is great.
Love it.
It's always fun.
I learned a lot. Thank you very much, Doctor.
I'm the student, you're the teacher.
Well,
Thanks,
it's a two-way street. Stay safe.
Bye-bye.
Take care.